So thank you so much for everyone joining us and welcome to the panel.
Okay, great. All right, so we're looking forward to a really great discussion today. And our first question is for Dr. Yep. So how do you counsel patients on the extent of thyroid surgery for differentiated thyroid cancer in terms of disease-specific factors known at the time of diagnosis? And what would prompt you to recommend active surveillance versus thyroid lobectomy versus total thyroidectomy?
Thanks so much. I just want to start off and say how much I love the title of this webinar because it really is shared decision making with patients. And so a lot of the times we're spending so much time and just trying to come to the right decision for both the cancer and also for the patient in terms of what's the best surgery. And so the way that I think about the disease is that when someone comes to see me with a biopsy that's positive for cancer, I try to think about it in two different sort of buckets. So number one are there any patient-specific things that would make me recommend one type of surgery or even active surveillance? And then are there any sort of disease-specific things that may lean towards one or the other? And so from a patient standpoint, there's certainly things like bilateral nodules, if they have underlying Hashimoto's thyroiditis, if they're already on thyroid medication, if they have a history of radiation or a family history of thyroid cancer, sometimes those can certainly lean more towards surgery and maybe potentially even total thyroidectomy versus initial lobectomy. Certainly there are many disease-specific things such as that may suggest a little bit more of an aggressive cancer. Things that we can see in the ultrasound, things that we can feel in physical exam, certainly lymph nodes that are positive. If there's anything on the biopsy, such as a more aggressive histologic variant, sometimes that can, again, lean more towards surgery and more towards a total thyroidectomy versus lobectomy. But otherwise, the decision between active surveillance and lobectomy and total thyroidectomy is often driven by a lot by patient and what the patient wants and what makes them the most comfortable. But certainly there's a lot that we do to help guide them through that process. There are certainly sometimes things on the biopsy, like molecular markers that can potentially help us, but that is still a little bit of a ongoing sort of research field. So.
Great. That's a great answer, Dr. Yep. Thank you. And I wonder if we could ask Dr. Patel a little bit more about what you just said about the molecular testing and sort of how, so Dr. Patel, how does mutational status, BRAF or TERT, influence your recommendations for treatment?
That's a great question. So this is a really kind of expanding and evolving field. The concept of looking at the genes or the mutations that are involved in the tumor really has only been around for a good maybe 15 years now, give or take, and more in clinical practice over the last decade, where most of us have been using it more routinely. It was initially really the way these panels came about. They were never really designed to look at the cancers themselves. They were really designed more to look at nodules that were indeterminate. So these are nodules that you had a biopsy, and the pathologist obviously couldn't tell you whether it was cancer or not. What we were traditionally referring to as Bethesda 3 and Bethesda 4 nodules. And so these molecular profiling tools were really designed to help us maybe better categorize these nodules which were indeterminate, kind of make them are these nodules more likely to be malignant or more likely to be benign? And I think that's where this whole field kind of started from. And that's really where we still utilize molecular markers to this day. So when we look at mutations, most of these mutations we're finding in these indeterminate nodules. Thyroid cancers, especially papillary thyroid cancers, are pretty much diagnosed when you do the needle biopsy. So we often don't have that information for biopsy-proven cancers. Every now and then we'll have, a stain or something, and it may say that this tumor may be BRAF positive. But as far as looking at molecular markers for prognosis and prognostication for thyroid cancers, that's kind of an evolving field. And I think we're probably going to be moving in that direction eventually, taking a look at cancers and seeing, what the molecular profile of that cancer shows, and seeing if that would alter our management. Will we do more aggressive surgery? Will we give radioactive iodine because the tumor has, a certain mutational profile. I don't think we're quite there yet. I think the field is moving in that direction. So I think you'll have to kind of wait and see how things progress.
Okay, great. Dr. Patel, thank you for that. It looks like we're going to have a really great discussion at the end. We've got lots of questions popping up in our chat. But before we get to that, Dr. Oltmann, what patient preferences and concerns do you consider in counseling patients on the extent of thyroid surgery for differentiated thyroid cancer?
Yes, this obviously is a question we tackle every single day with every patient in the clinic. I think a lot has to do with learning about the priorities of our patients. What are the things that keep them up at night? What are the things that they worry about? I also have a large portion of my practice at a county hospital where access to care becomes a concern and something that we factor in as well with any of the treatment paths. I think really some of the things that patients, I'll try to clarify if the patient otherwise is kind of the whatever you say mentality, which for thyroid cancer, this really has to be a team decision. And we want to learn about our patient to really help ensure we can make sure they know what they need to about the different treatment options to make the best choice for them. For some patients, it may be trying to avoid having to take medicine every day. And so whether that's through active surveillance or a lobectomy, those patients may be able to avoid or delay the onset of thyroid hormone medication. Obviously there are certain tumor characteristics that have to be met before we can really talk about lobectomy and active surveillance as an option. But if they do meet those criteria, other patient factors that may be helpful. Patients who have a history of gastric bypass, we sometimes worry about their parathyroids, little glands around the outside of the thyroid that help with calcium regulation, and trying to avoid a surgery that may put those glands at risk, like a total thyroidectomy and a central neck dissection, which may cause a lot of long-term calcium problems for that patient. Obviously, we really want to balance the risk and benefit for that particular situation. The timing of surgery can also be quite flexible, and that may come up in some of our patients who have other cancers that are undergoing active treatment or chemotherapy, or in our pregnant patients. Do we need to do surgery during pregnancy, or can it safely wait until after baby's born? There can be history of previous operations in the neck that may make the operative approach a little bit more difficult, or concerns about their vocal cord functionality and really making sure we have a good understanding of how well their vocal cords are working. That may also influence the extent of surgery. And then what really is the patient more concerned about? For some people, it's the thought of another surgery looming at some point in the future, or the anxiety of repeated tests, although they're still going to have those tests with or without the surgery, because these ultrasounds and blood tests are also how we surveil thyroid cancer, long term, making sure the cancer hasn't come back. But for some people, the thought that there's still something left in them, that's the bigger thing that keeps them up at night. For other patients, it's the thought of having to have a surgery, and can they avoid it or hold it off as long as possible?
Great, thank you. That's an excellent answer, I think, from the really looking at how patients think about thyroid cancer treatment, and there's certainly a lot of options. Dr. Patel, I wonder if you can tell us about the kind of hard stops for you for offering hemithyroidectomy. Are there any things that that kind of make you think that that's not a good surgical option for patients?
Absolutely, I think that's a great question. Most of our discussion with the patients is really just defining how much surgery is the right amount of surgery for each individual patient. So there are certain situations in which I would definitely recommend a total thyroidectomy. Obviously, for example, if you have tumors on both sides, right? If you have disease on both sides of the thyroid, you're going to most likely require a a total thyroidectomy. Any situation in which I feel that I want to follow the patient much more closely and use maybe thyroglobulin as a surveillance tool, or potentially have to give the patient radioactive iodine, so larger tumors, greater than 4 centimeters, more aggressive tumors, whether, histologically, if it's like a poorly differentiated thyroid carcinoma or something more aggressive. If on my imaging studies, I see that the tumor is extending into the surrounding tissues, I know this is going to be a more aggressive tumor. In those patients, I would definitely recommend a total thyroidectomy because they most likely will need radioactive iodine. And obviously we cannot give the iodine if you still have a whole thyroid lobe still there. And then definitely patients who have disease that's already spread, whether it's distant spread into the lungs or bones, or even regional spread into the lymph nodes. Those patients are definitely going to require a total thyroidectomy so they can get the adjuvant treatment they need. And then there are, more rare situations. For example, a patient with a significant family history where they have 3 or more individuals, first, degree relatives that all have had papillary thyroid cancer. It's unusual, but we do see that situation. And then, in New York City, we do still have a pretty large Ukrainian population here. And they were exposed to Chernobyl, for example. So, if you have a population of patients that have had prior radiation exposure, in those patients, I would definitely recommend a total thyroidectomy. So those are some of the, the indications for definitely doing a total thyroidectomy as opposed to a lobectomy.
That's great. Thank you for that. I'd just like to pause for a second and say, it's really nice to hear how our colleagues around the country treat thyroid cancer. And I think everybody's answers show exactly how nuanced it can be. Dr. Yep, how do you make the decision to perform a central lymph node dissection during initial thyroid cancer surgery?
Yeah, so I think the important part about the preoperative assessment is really getting a good look at the lymph nodes prior to surgery. And so that usually involves getting a dedicated neck ultrasound that's really focused on lymph node mapping or lymph node assessment. And that can often pick up lymph nodes on the side, the lateral lymph nodes that are concerning, and often I will biopsy those if they're indeterminate or if they're worrisome for cancer prior to surgery. It's not great at the central compartment, as we sort of hinted at. It can sometimes find obvious lymphadenopathy, but not always. And so during surgery, if I know that I have somebody with thyroid cancer, I'll do just a very good intraoperative assessment, just really looking and feeling around to make sure that I don't miss any obvious lymphadenopathy. Now, it's not perfect. And so there's still some situations where I will do a nodal dissection, even if the ultrasound is negative, and even if the intraoperative assessment is not concerning. So those include large tumors, anything over 4 centimeters, anything that has any obvious extrathyroidal extension, suggesting a little bit more of a local aggressive behavior, anything that otherwise, sort of raises any red flags prior to surgery. Now, all of that, the caveat to all of that is that it has to be safe for the patient. And so if there's any concern about the the recurrent laryngeal nerve at the time of surgery, then certainly I won't do that. But really, the main thing that we worry about with central nodal dissections are the parathyroid glands. And so if I'm even thinking that there's a remote possibility that I'll do a nodal dissection, I will be very, very careful with the superior parathyroid glands in particular, just to make sure that there's no issue. So it gets a little complicated, but I think nowadays we're a little bit less aggressive in the nodal central compartment nodal basin than we used to be in the past.
Thanks for that. Thanks for highlighting that. And I wonder, sort of off of that, if we could ask Dr. Oltmann if there are specific patient or disease-related factors that would prompt you to perform, a prophylactic central lymph node dissection, so one where you don't see positive lymph nodes, but would take the nodes in that area. And then I think there's just to loop this into one of the questions that came up about doing a central dissection along with a lateral dissection. Is a central neck dissection always done at the same time as a lateral neck dissection?
Thank you, Dr. Morris. So I'll start with the chat question first with regards to how to handle the central compartment when we have known lateral disease. In general, I will always clean out that central neck compartment if I have biopsy proven lateral neck disease. As Dr. Yip had previously alluded to, depending on the size of the thyroid, the body habitus of the patient, how long their neck is, our ability to really get a good look at the central compartment can be limited, even once you're asleep and completely positioned for surgery. A lot of us will actually repeat an ultrasound right before we start the surgery as sort of one last check for any surprises, because we're able to get a little bit of a better look with you relaxed in the operating room. But still, there's that concern if the disease has escaped the thyroid to the extent that we're seeing it out on the sides of the neck, we really need to get a very good clean out of that central compartment as well. That being said, there are some instances where we might see very tumors in specific locations in the thyroid that could skip or bypass the central compartment altogether, but that's really less common, and that central neck compartment is a lot more challenging to go back into if we've already taken the thyroid out. So we really want to address it the first time around if it needs it. As far as a true prophylactic central neck dissection, where my ultrasound doesn't have me concerned about any lymph nodes in advance, Dr. Yip, I think, mentioned the fact of what we find during the surgery, whether or not the tumor appears to be invading into what is around the thyroid, either the muscles right above it, the trachea, the muscles on the outside of the voice box, or even sort of wrapping around to the nerve to the voice. Those are all sort of clues to us that this is a more aggressive tumor, and we really need to make sure we've addressed everything up close. That'll usually trigger me to do a central neck dissection. The 4 centimeters occasionally will as well, but I'll put that more in consideration with the other patient factors, like a previous gastric bypass, if they're currently or have recently been pregnant and or breastfeeding, just because of the body's demands on calcium metabolism in those scenarios as well. I may be a little bit less prone to put that patient at higher risk for, problems with low calcium after surgery, whether it's short term or potentially whether or not it would be long term. Those are usually the main factors that I would use.
Great. Thank you so much for that. Dr. Yip, I wonder, and this, I know we've all been in this situation, unfortunately, but I wonder what your thoughts are on a patient who's already had surgery for thyroid cancer, and during surveillance, they're found to have enlarged lymph nodes on ultrasound. How do you decide when to intervene or when maybe follow-up would be reasonable?
Yeah, that's a great question, and the topic of probably a whole another webinar. I think it depends a lot on what kind of surgery they had initially and how extensive the initial operation was, and also a little bit on sort of the tempo of disease. So patients who have, small lymph nodes that have been there for quite some time and who may have already had aggressive surgery, especially if it was in my hands, and that usually I'm a little bit less aggressive about wanting to go back in. So if it's stable, we can potentially watch it for a little bit and really wait until it grows, or sometimes if the thyroid globulin levels increase, then certainly that would always be a possibility to go back in, especially in a previously operated compartment. If it's an area that has not been operated on, then certainly the risks of surgery are a little bit lower, and certainly it'd be reasonable to potentially intervene a little bit sooner rather than the first situation that I talked about. So I think it really depends on the nature of the disease. I just sometimes like to follow patients for a little bit just to get a sense for sort of that natural history of the disease. Often some patients can have small disease that is residual disease or recurrent disease that sits for quite some time. Sometimes we can use that as a way to give another dose of radioactive iodine to see if it's radioactive iodine avid, just to again get a little bit more understanding about the biology of disease before we think about intervening with surgery. So it becomes a little bit nuanced for sure.
Great, thank you. And then Dr. Oltmann, how do you think about reoperation in the central neck for recurrent differentiated thyroid cancer, what are your concerns? When do you decide to intervene? And I think there's a question in the chat that sort of goes to this in terms of what size is considered a small lymph node that's okay to leave and monitor versus what needs to intervention or even biopsy.
So, I think the first place that we would want to start is kind of getting an assessment of what happened at the first surgery. And so that includes getting a good exam of the vocal cords, ensuring that there's no subtle abnormalities of the vocal cord on one side or the other. Also having a good sense of whether or not the patient is needing supplementation with calcium. How did their parathyroids handle the last operation, and do our pathology report comment on the presence of multiple parathyroids in the specimen? Is there anything about the original tumor pathology that we're more concerned about, whether it's tall cell, a more poorly differentiated, versus a classical papillary? And then also looking at the initial operative report too, and that's where surgeons really need to leave clues both for themselves and for their colleagues if anybody else is picking up this patient in the future. When you have a difficult case, really being descriptive of where things were difficult, where there was local signs of invasion, or if everything really separated apart easily, where the concern for residual disease being left behind is pretty low. The biggest concern that I have about going into the central neck, we can't predict how people's scar looks on the inside by meeting them and looking at them on the outside. And that can really make finding these a little bit more challenging. I know anything really less than a centimeter in size in the central neck can sometimes be quite difficult to tease apart from the tissues around it. And considering there's a lot of very important things that are going to be very closely stuck to this residual disease, we really want to make sure we're not putting someone an undue risk to go after something small. And I think that's where Dr. Yip's strategy of closely monitoring the patient and getting a sense of how fast something is growing or progressing, or if it is actually fairly steady and stable, can really help. I would agree if the central compartment down below the thyroid hasn't been violated, initially may have a little bit lower threshold to go back, but if a central neck dissection had really been included with the first surgery, there's going to be a lot more scarring and it's going to be a lot more difficult to safely take that disease out.
Great, thank you so much. Well, those were the questions that we had prepared in advance. And as I'm sure everybody can see, we've got some really good thought-provoking questions in the chat. So I'm looking forward to hearing what everybody's thoughts are on our audience questions. So the first question is, are there any circumstances in which active surveillance would be an option with somebody who has had a biopsy that's confirmed papillary thyroid cancer in a small nodule, which sounds like otherwise, would otherwise fit criteria for maybe active surveillance, maybe hemithyroidectomy, and also a cervical lymph node? And I mean, for the purposes of the discussion, I guess we could just assume either it's a central or a lateral cervical node. So if not, and how long would you have to say, how much time does the patient have to really make a thoughtful decision about how to proceed? Dr. Oltmann.
Thanks. So I think that this is where a partnership and discussion between the surgeon and the patient is really important. I think if that lymph node has been biopsied and you know that it's cancer, that has shown us that the cancer is spread outside of the thyroid. And normally that would be a situation where we would be recommending radioactive iodine after surgery. That being said, for a lot of these patients, it can be a very slow growing process that perhaps in the right patient, a short period of active surveillance is reasonable. but understanding more than likely, especially with younger patients, they're going to have surgery at some point. And it's a balance of by going down the active surveillance pathway for too long, do you lose your opportunity to have a lesser surgery? You know, if this is a central neck lymph node, is this something that can be addressed with a total thyroidectomy and a central neck dissection? Depending on what the final path shows, it may alleviate some concerns about the need for radioactive iodine and allow for simple surgical treatment. Or with active surveillance, do we see progression of the disease? And now we've gone from just a thyroidectomy and a central neck dissection to involving the lateral neck. The lateral neck really is a new compartment of the neck. It carries with it potentially new risks with surgery, a much longer incision. And that for sure would buy someone some radioactive iodine afterwards, in my opinion. And so I think it's really ensuring the patient understands their part in being good with surveillance. It's not saying we're going to do every 3-month ultrasounds. It's probably going to be a 6 to 12 month interval to watch things. But depending on the phase of life you're on, if there's other things happening like pregnancy or chemotherapy for a different cancer, or other medical problems that aren't appropriately controlled, diabetes that's raging and horrible, or active heart disease. We do have patients in those scenarios where their other medical problems take precedence and the thyroid cancer has to be on the back burner. And I'm sure all of us on this panel have individuals that we have had to hold off on their surgical management of their thyroid cancer because something else was more important at the forefront.
Thanks so much for that great answer. Does anyone else have, if we can have other comments, or we can go to the next topic. There's a couple questions on the topic of shared decision making. Maybe I'll just switch to that. Patty and Nadine, both in the chat, are sort of asking a similar question. And I think this is with shared decision making is sometimes very complex. You know, do patients need more information? Patty's asking. There's a trend on giving decisions to the patient, but they don't always know what to decide. And I think Nadine is sharing much the same thing of, you know, sometimes I think I wish I just had the doctor to tell me what to do. How do you guys handle this?
So I think that's a great point. You know, and I firmly believe in shared decision making, but I also believe in educating and kind of reaching the decision with the patient. The one thing I personally don't like to do is tell the patient, go home and think about it and call me and let me know. I don't think that's the right answer and the right approach. I think it's a decision they have to make together. I do sometimes say, look, this is going to be an ongoing conversation. We don't have to decide today. You know, like that decision does not, and that's the beauty and the luxury that we have with this particular disease for the most part, is that we can talk about this. I've given you some information. Let's set up another meeting, maybe in a couple of days, and let's rediscuss what we just talked about, because this is going to be a conversation that's going to take a while, and there's a lot of information sometimes that we discuss with the patient, and it takes a while to really absorb all the different options. I often say there's no right or wrong answer. The beautiful thing about this is that you have all these wonderful right answers. It's just a matter of what's right for you. So, you know, that's the other thing, because patients often don't want to feel like they're making the wrong decision. If they feel like there really isn't a wrong decision here, they're all right decisions. It's just a matter of figuring out what's the right one for that patient. I think that means a lot. And then the other person in this shared decision making is going to be the endocrinologist or the referring physician, because often, you know, they may have a different opinion or a different thought process that they have discussed with the patient, and so involving that party is also very critical in this whole process.
Yeah, I completely agree, and I think this may address a little bit of what Nadine is asking. Is that when there's a right answer, where there's clearly data that shows one way or the other has a better outcome, I'm happy to say that, and I will say that there's no, in that situation, your outcome is going to be better if you take out the whole thyroid and take out the lymph nodes. And I think there's certainly many parts of thyroid cancer where we can say that the answer is pretty clear. But there's lots of aspects of thyroid cancer, which Dr. Patel was sort of alluding to, that are really they're equivalent. So if you do X or Y, low versus total for small cancers that are completely encapsulated and confined, the outcomes are the same. And so then it becomes, sort of taking all the aspects of the patient, whether you get radioactive iodine, for a low risk cancer with maybe a couple of small micrometastases, that is also a little bit of data that's not quite clear. And so I think in those situations, it becomes a little bit more of sort of the shared decision making. So I agree. If there's a clear answer, I hope that your doctors will tell you that. But I think that in many times when we are incorporating the patient and you into the decision making, it's not because we're trying to be difficult, but there really is no right or wrong answer. And there's so many other aspects about quality of life, surveillance, how easy is it, how for your endocrinologist to keep an eye on things, how easy is it for you to keep an eye on things. And so all these other things are things that we're just sort of learning about for the first time, and often additional visits can be very, very helpful in shedding more light on what's the right thing for you.
Dr. Oltmann, did you want to comment?
I was just going to add, for some of these things as well, and I think both Dr. Patel and Dr. Yip alluded to the fact that this isn't something that you have to rush to make a decision for, and most of the surgeons and endocrinologists who are really focused on thyroid cancer will lead you, if it is something that is time sensitive. If it is one of those smaller percentages where it's like, no, we do have to make a decision, we do need to act, but that's the minority of the time. Most of the time, there's a lot of time and flexibility. There is time to think about it. And while I may have the conversation and tell people to talk with their family, and then instead of having them call me back, I bring them back and say, okay, what questions came up when you had more time to think about it? And what other issues did your family bring up? And this is a type of cancer where we do have the luxury of that time to make sure you don't feel rushed or pressured into doing something that can't be undone. I think that is where finding not just an endocrinologist who's comfortable with thyroid cancer, but also a surgeon who's really well versed in thyroid cancer can make all the difference in the world, because neither of those should really be making you feel pushed or rushed into any decision making, with very, very few exceptions. And that's where Dr. Laird had mentioned the AAES, our website, both for patient information at endocrinediseases.org, but also endocrinesurgery.org or endocrinesurgeons.org, where you can help partner and find a local expert that's close to you, so that you can seek out someone who's going to be well versed in the nuances of this disease and the nuances of your treatment, not just the technical piece of how do you take out a thyroid.
Great, thank you so much. All right, we've got one more question in the chat that I want to make sure we get answered. And I have to say, this topic is something that always gives me pause, whether it's a patient who's been operated on somewhere else or it's one of my own patients. And this is a great question. What are the risks of operating twice in the thyroid region? So if somebody's had thyroid surgery first, or even maybe a prior neck dissection, what are the risks in those situations? Anybody open to take that one?
I mean, I'll take it. That's fine. So I think both Dr. Yip and Dr. Oltmann both already touched upon this a little bit in their discussion. Anytime you're going back into a surgical field that's already been operated on, it's really critical and important to know first and foremost what was done the first time. So looking at the prior surgeon's notes, I mean, even if it's your own case, looking at your own notes and and realizing what you did the first time around, the extent of surgery that was done, and then also looking at the pathology, because that's going to be critical and important as well. So like if the pathology report states that there were maybe 2 or 3 parathyroid glands that were incidentally removed, that'll give you some pause when you're operating in that central neck again, saying this patient may only have maybe 1 or 2 functional parathyroid glands left. And, and that's a potential risk that needs to be discussed with the patient, that there's a, although it's still small, there's still a slightly higher chance that the patient may end up with transient or permanent hypoparathyroidism, which could be a quality of life issue for sure. Similarly, all these patients definitely need some form of a preoperative laryngeal exam, just to make sure that their vocal cords are still functioning properly, because that may change your decision-making process. It may make you, think again whether or not you want to go back into that certain area or maybe approach it in a different way. And then the final thing I think is what Dr. Oltmann was just talking about. You really want to find somebody who's an expert in this. And sometimes, going back to your old surgeon is great. And if your prior surgeon feels comfortable going back into the neck and redoing the operation, that's fantastic. If your prior surgeon says, look, this is going to be a little bit more complicated, it may be beyond my scope of expertise, then seeking out somebody who really, is an expert in thyroid surgery, using the endocrine surgery finder, et cetera, to find somebody who can really do this and who does these kind of operations is going to be critical, because the risks are slightly higher. There's no doubt about it. Risk of injury to the recurrent laryngeal nerve, risk of injury to the parathyroid glands is higher when you're going back into an operated field.
Thank you, Dr. Patel. You mentioned something important. It's a segue and something I was going to bring up again, just to make sure we covered it before we disconnect. But I think it's a good opportunity to highlight the importance of, especially in a situation like this where you may need reoperative surgery, finding a high volume surgeon. So a surgeon that does a lot of thyroid surgery, and along with that, a lot of surgery for thyroid cancer and neck dissections, et cetera. So if you look at our website, which is endocrinesurgery.org, you can use the surgeon finder, as Dr. Patel mentioned, to find an endocrine surgeon in your area. Are there there's another question. Hold on, let's see. This is great. This is a really good question. I think this is a good question for everybody. The website again is endocrinesurgery.org. So www.endocrinesurgery.org. I can type it into the chat in just a minute. Okay, so what's the difference between an endocrine surgeon who specializes in thyroid surgeries and a head and neck surgeon who specializes in thyroid cancer? Dr. Patel, you may be the best equipped to answer this question.
Sure, I'll be happy to take this question. So once again, it's all about high volume, right? So instead of differentiating, whether it's a head and neck surgeon or an endocrine surgeon, it's all about volume. So, if you have an endocrine surgeon who's doing, tons of thyroid surgery and reoperative thyroid surgery, then that person's an excellent person. Similarly, if you have a head and neck surgeon who is focused his or her practice in the management of thyroid and parathyroid diseases, who has a high volume practice, then that person is probably just as equally qualified. So I don't think, I think it's all about the volume and what you've dedicated your practice as far as thyroid and parathyroid surgery is concerned.
I just add on to that the high volume piece and the understanding of thyroid cancer surgery and thyroid cancer behavior is really critical, because by going to see one of those high volume surgeons, you may learn actually you don't need that reoperation, and that someone who's not as comfortable with the disease process, be it the endocrinologist or the surgeon, may be pushing for something that actually can be very safely observed. And that's where ensuring you have a high volume thyroid surgeon, a high volume thyroid cancer endocrinologist, to really ensure you're getting the best recommendations for yourself.
I think that's a great point, and I think our panelists have really emphasized that it's not just about I would say not just about the volume of surgery in the neck, but about the decision making for this particular type of surgery that is really important. There are some very excellent surgeons who operate in the neck all the time, but don't take care of a lot of thyroid cancer. And I think that kind of, pre, intra, and post-operative decision-making can be really variable based on kind of the volume of thyroid cancer patients that you're actually seeing. So I was going to ask, an anonymous question about they just had radiation. Oh, can you just have radiation to take care of thyroid cancer? Are there non-surgical options for thyroid cancer? Does anyone want to take that one?
If it's a known thyroid cancer, often surgery is curative. And so sometimes that is sort of the first branch when you come back with a diagnosis that's thyroid cancer. But as we have sort of mentioned, certainly in many situations, active surveillance is a possibility in small cancers that are completely confined, that don't have any evidence of lymph node metastases. It is certainly an acceptable alternative to surgery. The other alternative that's really still under some investigation is the use of radiofrequency ablation for thyroid cancers, but that is not yet sort of mainstream. But there are some studies throughout the country, I think, that are being started for use of RFA for treatment of, again, small thyroid cancer. So I think there are many options for thyroid cancer. To my knowledge, I don't know of any specific radiation therapies, but I think often radiation therapy has its own side effects, and so I think that is probably not yet considered to be the first line treatment for cancer if you're otherwise a candidate for active surveillance or surgery.
Great, thank you so much. We have another really great question from our patient audience. This person just didn't have all the right information when they had their surgery for thyroid cancer. It sounds like maybe there was a complication, or their postoperative course was difficult. What they're asking is, how do we try to reach patients early in their treatment so that they can make informed decisions, or how should we approach educating patients better? And I'm going to expand this a little bit, and I'm going to say, how do we inform our colleagues better? Meaning, not everybody can come to New York City and have thyroid surgery, or go to Pittsburgh, or go to Dallas. So anybody have any thoughts on that? Dr. Oltmann, Texas is a big place, so let's start with you.
So I think, a lot of us try to partner with organizations like ThyCa to really engage where patients may have their first contact once they have a diagnosis. And then through our various different professional organizations, both the AES and many of us, actually all of us, I think, are also members of the American Thyroid Association, to really help ensure that we are providing the most social media awareness and access on the internet based on where people are going to tend to look. And unfortunately, we don't have the ability to reach everybody, but we are trying to sort of broaden that network through the various different social media platforms, our own organizations' websites, and patient education portals. And then many of us in our own communities, in addition to partnering with the local chapters of ThyCa, also try to partner with our internal medicine colleagues and our family practice colleagues, who may be the ones who are diagnosing these, to help ensure that on a physician level, we're accessible both for education and for any questions that come up, to really help direct care as soon as possible.
Any other comments? We have a couple other questions that it'd be great if we could cover, but along that topic, anybody else have any comments before we move on?
Are there other specific websites that people direct patients to? I know we've recommended a few, and I know ThyCa has amazing information.
Yes, I think it's always important to talk to patients about where they're getting their information from, because there's a lot of stuff, obviously, on the internet that's not that accurate, and so they have to be careful. I really try to guide patients towards professional societies and professional organizations, such as AAES website, the ATA website. ThyCa, like I said, has great resources. So I think those are really where the patient should be trying to get most of their information. I would really try to avoid staying away from patient blogs and individual, websites that have been created by individual people. I just feel like those probably sometimes more, more advertising and not necessarily real factual information that the patient, really should benefit from.
Great, thank you. This is a really good question. I don't even think a patient has asked me this question, not one of my patients. What about somebody who's had radioiodine for Graves and then develops thyroid cancer?
So I'll take that just because we just did a study on that. So I can tell you, we just reviewed our patient. And so, the question obviously is, does that radiation exposure, does it predispose a thyroid gland to developing a cancer, was kind of the question that we were asking. The truth of the matter is, the data did not necessarily show that it increased the risk of thyroid cancer. However, in our patients that did have prior radioactive iodine and developed a thyroid cancer, we tend to recommend a total thyroidectomy over a lobectomy for those patients, just because they have been exposed to radiation. So we do consider that a radiation exposure kind of a situation. If you can have a small cancer on one side, patients had radioactive iodine in the past for Graves' disease, we're most likely going to recommend a total thyroidectomy. Most of those patients are already on thyroid medication as well. So really saving the other lobe doesn't really offer much. And potentially there's an increased risk of developing cancer on the other side at some point. So that was kind of our conclusion.
If I could just add on to that too, I think a common scenario we'll also see is not necessarily a known cancer, but now there's an atypical nodule and they've had Graves and they've had radioactive iodine in the past. The radioactive iodine does kind of confound the picture because it makes it a little bit harder for our pathologists to feel confident they're seeing normal cells. The inflammation and the damage from the radioactive iodine is going to make things a little bit more obscure on the cytology. That's where the molecular testing can be a little bit more helpful to know which nodules we really should be worried about. And then again, sort of how long ago was that radioactive iodine, I think may also influence. If the radioactive iodine was in the last couple of years, probably not quite as concerned about it leading to a malignant transformation, but 15, 20 years prior, that definitely can be. And that's for our patients with Graves' disease, something to be considered before they're undergoing their different treatment option discussions.
Great, thanks so much. I think this is another really important question. We were just answering this in clinical thyroidology for this next month. How soon should radioactive iodine be administered after surgery?
I think probably an even better additional question is, how long can you wait? That's the harder one. Sorry.
I think both of those questions are difficult to answer. I don't think there's any, unless maybe I should refer to clinical thyroidology this month. But I think the convention has always been that 6 to 8 weeks after surgery, you can get the radioactive iodine, but that's really based on T4 levels, which I'm not sure that it's still relevant nowadays. And then I think there are, again, some conventional wisdom, which I'm not sure is really based in sort of hard, firm fact, is we typically try to give radioactive iodine within 6 months of the diagnosis. I guess but again, I don't know that there's been any study that has said you have to have it within a certain time frame, or else it's no longer sort of valid, so to speak. And so I think that there's probably not any hard and fast rule, but those are some guidelines that we try to stick to.
So I think the other thing you also have to remember is, what is the iodine being given for? Is this an ablative dose? Is this a therapeutic dose? What's the reasoning for the radioactive iodine? And so if you have a patient who has distant mets with, let's say, significant amount of bone disease or lung disease, you're probably going to want to get that iodine in a little bit more quickly than 6 months or 4 months. You know, like that patient, I think, is a different situation than in someone who you say, look, I did a great operation. I know I got it all out. There may be some microscopic disease somewhere, and I want to try to maybe prevent a recurrence in, you know, in 4 years or 5 years from now. You know, that patient, you obviously have the luxury once again of waiting and giving the iodine at some other future point. You're not actively trying to treat metastatic disease that you know that exists. So I think, you know, it depends on what exactly is the goal of the iodine.
All right, and just to squeeze one last question in before we're at our end of time. Robert is asking about long-term thyroid hormone replacement, and what's the risk of developing something like atrial fibrillation or osteoporosis? I just like to say this is where I defer this question to endocrinologists who are smarter than me. But let's see who wants to take a stab at this one.
I think part of the long-term TSH suppression, a lot of it has to do with how tightly are you being suppressed. And then are they also monitoring your T4 levels in relationship to that, and really ensuring that your medical endocrinologist is balancing your personal risk of cancer with the appropriate TSH suppression. Over years with no evidence of disease, you really don't need as tight of TSH suppression in many instances. And it's that long duration of high T4 levels and undetectable TSH that will cause a cumulative risk for developing bone demineralization or atrial fibrillation. It really needs to be an individual conversation with your medical endocrinologist based on your age, your other comorbidities, and your thyroid cancer profile. And so for young patients, probably not going to have any of those issues. For our older patients that may already have some pre-existing heart disease or bone disease, definitely want to take that into consideration.
Thanks so much for that great answer. And just to wrap up, I think we're out of time. It's been some really inspiring questions. And I just want to thank our panelists, my co-moderator, Dr. Laird, and Gary Bloom and ThyCa for giving us the opportunity with the AAES to join in this amazing conference. So thank you so much, and you can find us. You can find at the endocrine surgery website at AAES, endocrinesurgery.org. And thanks again.
Bye, everybody. Thank you.
Thank you.